is Dr. Adrian Baranchuk, who is Professor of Medicine at Queen's University in Canada, Editor-in-Chief of the Journal of Electrocardiology, Vice President of the International Society of Electrocardiology, President-elect of the Interamerican Society of Cardiology, comes to us from Buenos Aires, Argentina. He is a practicing cardiologist. He's published more than 725 papers. He's got numerous awards for his teaching skills, and I think you'll very much enjoy his talk today and learn a lot. Welcome, Dr. Baranchuk.
Thank you, Brian. Thank you so much. It's a great pleasure for me to be able to participate in this meeting. I want to congratulate Dr. Brissett and Dr. Jutras for their presentations. Sometimes it's difficult to start a presentation after you hear two amazing investigators and wonderful speakers. So it was my first time listening to them. I read their papers, but they are also fantastic communicators. So before we start, I want to show you my disclosures. I do not have any financial arrangement or affiliation with any commercial entities whose product, research, or services may be discussed in these materials. But I do have some disclosures. I feel very happy and honored to be able to work with both Pat Smith from LDA and with Professor Brian Fallon. And seeing my picture in this panel makes me very proud and happy to be able to contribute with a little bit of knowledge around Lyme carditis. So for those that are not familiarized with that, I'm going to talk about Lyme and the heart. But I am not an ID doctor. I am an electrophysiologist doctor. So don't ask me tough questions, otherwise we may need the help of Catherine and Brandon. I'm going to touch briefly on current epidemiology of Lyme disease, some risk factors, and basically I'm going to spend most of my time talking about Lyme carditis and how Lyme carditis is part of the big picture of Lyme disease. I'm going to show you some of the Queen's approach that we're super happy that now several teams around the world are embracing and using our risk score and our approach to the management of this condition and some future considerations. There's a lot of stuff that you already know that the more than 110 people in the audience knows, so I'm going to move faster. Remember that even when we have a peak seasonal, we see Lyme disease and Lyme carditis through the fall and the winter as well. And as you know, Lyme disease is quite extended in Canada, and I particularly live in an area that was found to be specifically endemic. So here is a map that is showing you the southeastern Ontario, and Kingston, which is my town, is in the middle of a high density infected ticks area. And that is pretty much well covered by our public officers. You know better than me how the epidemiology is changing in the States, and it's moving southern and western. So this map is now changing as we learn more, and we have better methods to establish the distribution of infected ticks. This is just to call your attention on increasing numbers of cases that are reported every year. And the same thing happened in the States in the last decade. With a group of colleagues from Mexico, we started, and this is on just 3 years ago. Now the map is way more extended. We had a lot of pushback because there were groups that were considering that these were imported cases from Mexican returning from the US after traveling or after being rejected or expulsed. And now it's pretty clear that there is a local community transmission, and that Lyme disease is now endemic in Mexico as well. And I know that you're very well familiarized with the different stages associated with Lyme disease, and we try to have a uniform way of denomination for that, where we have an early localized, an early disseminated, and a late disseminated. But what I want to call your attention is in which of these states Lyme carditis has a role, at least up to October the 2nd, 2021. Lyme carditis belongs to the early disseminated stage of Lyme disease. That means 30 to 60 days, give or take, since the tick bite. And this is quite important. Just yesterday, I saw a patient that traveled 400 kilometers within Canada to come to see me, and her tick bite occurred more than 20 years ago. And she defied all the laws and all the systems, and I was very happy to have her. Couldn't convince her to do an initial phone visit, but for a tick bite that occurred 20 years ago, up to today, we still do not have a physiopathological model that could explain some of the symptoms in the absence of a structural heart disease 20 years later. And if there is a structural heart disease, there should be a comprehensive approach to understand if that has anything to do with a primo infection that occurred so many decades ago. So for the early disseminated Lyme carditis, which we, depending on the series, we keep quoting 4 to 10%, is that I want to put more emphasis. First of all, a quite recent few weeks ago paper on more than 500 kids presented to the emergency room with evidence of Lyme disease. This is coming from the States. They did something that I've been advocating for the last 4 or 5 years. They did systematic ECG to every kid that came with that. And now the incidence of possible Lyme carditis increased to 20%. So that 4 to 10% obviously is affected by the way that we do the search for cardiac involvement in the context of Lyme disease. The less we see, the smaller the number. The more we search, possibly the larger the number. And I am not asking here to do cardiac MRI to everybody. I'm asking to do a $1, easy to transfer, very reproducible 12-lead ECG. So basically, Lyme carditis represents at least 5 to 10% of all Lyme diseases, and from all of those presenting with Lyme carditis, at least 8 or 9 of them will present a clear manifestation of alterations on the electrical system, from a complete shutdown that we call high-degree AV block to different manifestations. For ages, we thought that there was a predominant tropism for the upper zone of the AV node. Now we have cases reported with bundle branch blocks, with infranodal blocks, and with supraventricular and ventricular arrhythmias. So again, the more we learn, the faster we change those paradigms that if it is not presented like this, it cannot be Lyme. So my first tip of the afternoon would be, if you're seeing a patient with high suspicion of Lyme disease, please do a full interrogation about cardiac symptoms and consider including a simple 12-lead ECG, and anything larger than a first-degree AV block or more serious than a first-degree AV block should be considered as a potential Lyme carditis, and then we can treat this accordingly. I would like to use few cases And you know that I like to bring cases to my presentations. So today I sub-selected cases that are important because somehow they are outliers of what we have been saying for the last 3-4 years. So in this case, I got you a female. Remember that our density was 9:1 men to female. That's a female, and it's above 50 years of age, which is, to start with, an outlier in the classic male and younger than 50 years old. She lives in an endemic area, retired from police, and she presents few visits to the ER because she presented with an inspecific rash in the shoulder, the right shoulder, that was treated first with antibiotics, then as a cellulitis, then only for a week, then with corticoids. In her 4th visit, because she presented with not a clear fainting episode, but the feeling that she was going to faint and some palpitations, someone does an ECG and finds a very prolonged 1st-degree AV block. So she's admitted to hospital. I'm consulted, and we started, after taking serology, IV antibiotics. This case ended up published last year in CMAJ with permission for reproduction from the patient. And as you can see, this is this triangular shape a rash that has nothing to do with the classic bullae. So I am introducing a second tip of the afternoon, is the classic super duper easy to recognize rash is only seen in 20 to 30% of the cases. So don't disregard rashes that could be in the context of high endemic risk manifestations of Lyme disease. So as you can see, I know that some of you are not very familiarized, but these tiny little bumps are the contraction of the atrium, and the big sharp signals are the contraction of the ventricle. It should not be such a big space between the two of them. That is clear something that is occurring in the conduction system. But this lady, now with 3 outliers, female, more than 50, and atypical rash, have an unclear evolution. So far, our patients come with very high degree AV block. Through the 2nd, 3rd day of antibiotics IV, they start to improve. This lady came with the less serious of all degrees of AV block. But look what happened. By day 2, now the things are getting worse rather than better. Of course, I'm in church and I'm thinking, this is not how these patients evolve. Still, she was producing enough beats, so it was not necessary to put a temporary wire. The story is, I just got the discharge ECG, which is much normal. The story is that up to day 5, she keeps deteriorating. So at some point I said, bear with me, because I'm still convinced that you have Lyme Carditis. But I was going home and calling my fellow and doing extra ECGs, trying to convince myself. And then on day 5, she starts to improve. And by day 10, we were able to discharge her. And this is her normal ECG at a 1-year follow-up. And I'm going to talk about this later, because now we have cumulative evidence of what happened with the patients that we treated for Lyme Carditis with an average follow-up of 2 years. Let me move to case number 2, 28-year-old male, classic. History of tick bite. Remember, I only got 40% of our patients recollecting the tick bite, so this helps a lot. The patient comes with high degree AV block. You see all the difference with the prior case. His echocardiogram is showing that the 3 layers of the wall of the heart is involved in the inflammation. At admission, there is an independence of those little bumps from the rest of the high spikes. By day 3, the thing is really serious, And now the patient is experiences long pauses. When you don't have one of those big spikes, the heart is not moving, it's not moving blood through the body. These small spikes are intentions of the upper chamber of the heart to make conduction, and they are completely blocked. By day 12 of antibiotics, the patient has a completely normal ECG. 5 years ago, myself, Adrian, would implant to this 20-something-year-old kid a pacemaker for the rest of his life. That would indicate that every 8 to 10 years, I have to do a surgery to remove the battery and put a new battery at the cost of 2 to 3% risk of serious infection, including dying at least 5 to 6 times in his lifespan. And I exchanged that by 12 days of admission. So when I have a manager that questions why I have a patient admitted, then I check the numbers and I say, hey, listen, you want to spend this money now, or you want to spend all that amount of money in the next 60, 70 years of life of this patient? And then as we learn more, we started to change our approach at Queens. At the beginning, for ECGs like the one on my left, we were implanting something called a temporary pacemaker, but that could make the patient to be in bed without moving for all the period until the things get better. And we're talking here 20-something-year-old kids that were like this case, a guy working in the roofs, and I have to tell him for the next 5 days you won't be able to move. This is something not very easy to achieve. So what we decided to do is to do temporary pacing when the heart rate is very slow, and that means that they have a lead to the heart that is externalized, connected to a battery, and the battery paced on the chest. As a proof of concept, the first time that we did this, I asked that was a 22-year-old male case, and I asked him from the table to walk the corridor to the cardiac unit. So we did a recording of that that had a lot of impact in the media. So I exchanged 5 days in bed for a 45-minute surgery, and then the patient being able to walk to bed. So now I can connect him to a telemetry unit, and the guy can walk, go to the solar room, grab a coffee. He doesn't need to be waiting in bed until he gets better. Of course, this temporary permanent approach can be removed as the patient improves, and the patient may not require permanent pacemaker. And you are familiarized with this publication we did in American Journal of Cardiology 3 years ago. At that time, it was our first 5 series, look at the ages, all right? So this is why my lady at 56 was considered an outlier. No permanent pacemaker implanted in none of them. Now we are at 14, no pacemaker implanted. So Lyme carditis can be, and it is, an early manifestation of Lyme disease, early disseminated. When a patient presents with an unexpected severe conduction disorder, think Lyme. And for that, we have created something called the SILC score. Yesterday, there was a new publication from a different group underscoring the value of the SILC score. And as an investigator, you cannot be happier than that they applied, and then they put a temporary permanent pacemaker, and then the patient went home on no pacing. Remember that when you see any degree of block in the context of early Lyme disease, the progression to fatal forms of conduction disorder can occur very rapidly. Early treatment with antibiotics may prevent having to put a pacemaker, which it's very difficult to deal with the patients once the pacemaker is implanted. That will be the last comment of my presentation today. So please, before considering implanting a pacemaker, if you are suspecting that this could be Lyme carditis, give the patient an opportunity. Put a temporary system, give the patient antibiotics, and be patient and wait. And this is the so-called SILC, the Suspicious Index in Lyme Carditis, which uses an acronym that one of my fellows invented at that time, and I love it. which is the COSTAR. C for constitutional symptoms, fever, malaise, joint pain, all these specific things that are difficult to link definitely to Lyme disease. That gives you 2 points. If you live in an endemic region and you practice outdoor activities, you get a point, 1 point for sex male, 3 points for the recollection of the tick bite, 1 point for age less than 50, and 4 points if you have the classic erythema migrans. So I remember my talk in Stanford when I was saying, guys, if you have high degree AV block and an erythema migrans, you have Lyme carditis until you demonstrate otherwise. And that was maybe the first time in my life that I got a stand-up ovation. So something that I want to clarify is the entry of applying the silk score is when a patient presents with high degree AV block, not when a patient presents with Lyme disease. When you present with Lyme disease, what you have to do is please include an ECG on your evaluation and check if there is something in the ECG. But if you are in the ER, if you're a family doctor and a patient, young male patient comes with an unexpected AV block, put Lyme carditis in your differential. You have to put Lyme carditis in your differential. Your physical exam has to include the whole body. 2 months ago, I take over the cardiology ward. There is a patient presented with atypical chest pain, no electrocardiographic manifestations. Angiogram is normal, CT is normal, echo is normal. So I am facing with the challenge of trying to find what's going on with this patient. So the patient is presented to me and said, okay, let's do a cardiac MRI and figure out if there is any inflammation of the heart. The same morning, as I was knowing my 18 patients, a nurse practitioner comes to me and says, Dr. Baranchuk, can you come and check this with me? Because I have never seen a bullseye rash, but this lady seems to have 3 of them in her back. She was the only one that examined the patient. I go there and I had to run out of the room because I was so emotional that one of my nurses gave us the clue of a patient that has admitted for 4 or 5 days, spending a lot of money in the hospital. Yes, it was an atypical presentation of a Lyme carditis case. The rash and something in the heart, troponins, which are those cardiac enzymes, were high. She didn't have coronary artery disease. Of course, the cardiac MRI confirmed inflammation in the infrabasal aspect of the heart. Physical examination. So when you have more than 3 points in the silk score, you have intermediate, and more than 7, you have high probability that that complete AV block is due to Lyme carditis. And the sensitivity of a validation that we did retrospectively, this is not the best science method. This should be done prospectively, but in my center, I have 4 or 5 cases per year only. So I need to do this as a multi-center stage, how to validate the silk score. I arrived to a sensitivity of 93.2%. Of course, I cannot prove a specificity, and this needs to be prospectively validated. And then 2 years ago, at that time, Ms. Young was a med student. We advanced what we consider the first and only algorithm for the management and treatment of patients with Lyme carditis that made it to JAC. So if the patient presents with high degree AV block, apply the silk score, it's here for you to remember, and that will give you low, intermediate, or high probabilities of this high degree AV block being due to Lyme carditis. If the probability is low, treat this as per standard treatment, implant a pacemaker if needed. If you have an intermediate or high, get the samples immediately for serology. In my place, it still takes 4 to 5 days to return the results. We need, with the help of Catherine, Brandon, and all our microbiologists, we need a stat test. As I test for troponins, I want to test for Lyme. Just tell me in the next 2-3 hours if my patient has Lyme, yes or no. And we start antibiotics. If the patient is quite bradycardic, we may need to consider putting a temporary permanent pacemaker. If not so bradycardic, strict cardiac monitoring. The patient does not need to be in the cardiac care unit, can be in the cardiology ward, but with a telemetry unit. Because remember, things can go on the opposite direction. Is serologically confirmed Lyme disease? If the answer is no, that opens a window that I would like Pat Smith and Professor Brian Fallon to invite me next year, which is the concept of Lyme Carditis with negative serology. This is a huge fight for me. I have brilliant ID doctors that have problems to buy on my concept that Lyme Carditis is not a serological disease. It's a clinical disease. So if the patient had a tick bite and had a bullseye and the serology is negative, that is Lyme Carditis anyway. But I have problems to convince them of that. So I may need to find a large series of patients with this. Thanks God, this is not a very often situation, but it happens. So if it comes positive, we continue with IV antibiotics for 10 to 14 days, and then we move to oral antibiotics to complete 3 weeks of treatment. If within the admission during the antibiotic, one-to-one conduction, that means one little bump, one big sharp signal are not achieved, I have to put a pacemaker anyway. But you know what? In those 14 cases, I have zero patients falling in this category. Zero, none. All of them recover conduction, but I want a proof that that conduction will allow them to do their normal life. So we do a stress test. We put them on a treadmill before the discharge. And then this is quite technical, but if they are able to increase their heart rate above 120 beats per minute, I see them with an ECG at 4 to 6 weeks. If they did it between 90 and 120, that means that at 120, between 90 and 120, the conduction start to fail, but I stop the exercise and they go back to normal. I bring them at 4 to 6 weeks, but I want to see another stress test to see if they needed only more time to completely resolve the inflammation. But if below 90 beats per minute, the electricity fails, they may need a pacemaker. But you know what? None of the 14 cases fall in this category yet. So we have patients in this one, we have patients in this one. They are seen at 4 to 6 weeks with or without a new stress test. And from there, we take action. This was the central illustration of that paper, just to show them how many times patients attended ER or saw their family doctors or other internists until the diagnosis was done. That is the purpose that we have for continuous education on this topic. And the more we do, the more we learn. Last year, with 2 med students now, we presented a case, 20-something-year-old kid that was admitted in a different hospital, and the doctor called me as an electrophysiologist, not because of Lyme Carditis, but because he ordered a Holter. He sent the patient home, ordered a Holter, and he saw that the motor of the heart now is stopping. It's different than a block in the conduction system. I see that. I start asking questions to the doctor, and I said, would you mind call your patient, send it to the ER, take serology, admit the patient in your hospital, and monitor him. He does all that. In B, you can see the stress test at day 10, and in C, you can see the ECG during the follow-up, completely normal, despite having this 6.5 second pause in the heart few weeks prior. And then this is what I was telling you about the long term. So now we have 7 patients that have completed more than 12 months follow-up with a mean follow-up time of 21 months. They have been clinically seen by our team, ECGs obtained, they are doing their normal life, they have not recurrence of Lyme disease, they are not on longer treatment antibiotic. Something that I learned from Dr. John Alcott is to include now in my data collection form questions to learn if people with well-resolved Lyme carditis may have symptoms of long-term Lyme disease. 0. I can't explain it yet, but so far I don't find evidence in properly treated individuals of a long-term manifestation, either in the heart or general symptoms. This got recently published in Current Problems of Cardiology by one of our residents at Queens. About living with a pacemaker. What is at stake here? If you have a pacemaker, that increases the risk of infections or sepsis per life. You go to dental extraction, you go to surgery on any other part of your body. You have a piece of hardware in your heart, you are at a higher risk of infection. Increases the risk of the tricuspid valve regurgitation and heart failure. Why? Because there is a cable crossing that. So when the valve closes, it closes over a lead that is stuck there. Increases the risk of aggravating heart failure if you have a second reason to have a heart failure. Yeah, of course, at the age of 22, you have no reasons. At the age of 72, you have plenty. Promotes an alteration of the synchrony between the contraction of the ventricles, because now, rather than being depolarized as nature, God, you name it, made us, you're contracting your heart artificially through a pacemaker. And I explained the battery replacements. So I did that introduction to discuss the last case and to finish in the next 5 minutes. 60-year-old man, outlier, above 50, presented with complete heart block to a different hospital than mine. They did a pacemaker insertion due to heart block in May, and they suspected, given the absence of any other risk factors, that this patient could have Lyme disease. So they obtained a serology, and a week later, they contact the patient and say, this has been positive. So they gave him a 3-week course of doxycycline. 6 months later, the patient moves to my area and comes to my pacemaker clinic and asks for Dr. Baranchuk because he heard about the Lyme Carditis thing. We have the ability to interrogate the pacemaker and to determine how much he has used his pacemaker since implant. And it was less than 1%. So this gentleman, and remember that if I program the lower rate at 60 and the patient goes to sleep, he may use it for a few beats during sleeping, right? So what do we do? He's not using this pacemaker, but the pacemaker is already inside the body. Few months later, the patient is using the lead in the upper chamber. This is a pacemaker with 2 leads, one in the upper chamber, one in the lower chamber, less than 2% of the time only at night, and less than 1% of the time in the ventricle only at night. So I decided to do a full evaluation of his case as if he did not have a pacemaker. So he has a normal heart. He does a stress test and he reaches 150 beats per minute with 1-to-1 conduction using his own heart without intervention of the pacemaker. So these are the technical reports of the pacemaker showing you the histograms, so to validate what I just presented to you. So the question is, what do we do now? Because the patient is already implanted. After 1 year of implant, it's not a matter of taking the device out. We need to use a laser extraction system. And when we do that, there's up to 2% of serious complications, including dying on the table. So I have only a few months to decide, do I keep this pacemaker because it has been already implanted, what a pity? Or what I decide to do is to explain to the patient that given the fact that he was properly treated and he passed all the tests, I am happy to consider manually extracting the pacemaker at a risk of complications less than 1%. Long chat with the patient and the family, complications of extraction fully explained to the patient, explaining this correlation with non-implant patients was key for he to take a decision. My colleague, Dr. Chaco, explanted this pacemaker in April 2021 with no complications. And up to now, September, the patient, October now, but up to September that we saw him for the last time, patient doing his completely normal life. We have now 2 patients. I explanted this one in April, and then a lady, identical story in May. So we had to go 2 times through expensive measurements, expensive procedures to recover from a wrong decision made during the process of deciding to implant a pacemaker. That's why we want to go one step farther with education. Something, the ECGs of the patient, something that I want to tell you before going into the current CIDC status quo is that we had the opportunity to partner with Galaxy in the US, because remember that my leads are screwing through the tissue. So when we bring them back to remove the pacemaker, there are few cells there. So we sent those cells for analysis of PCR. Both cases came back negative. Does it mean a lot? No, it's less tissue than a biopsy. But in those 2 cases where the antibiotic was aggressively given for the right amount of time, there was negative presence of bacteria within 6 to 9 months or 10 months later. So this is coming in a new publication. The CDC it has a blog now on Lyme Carditis. I am super proud that they are recommending just the work done with the student as part of the suggested written material. I will be happy to take your questions. Thanks again for the invitation.